Before we begin, I would like to say thank you to our speaker, whom you will meet shortly. I would also like to thank our event supporter, Hillrom. We would not be able to provide events like this if not for their generous support, so thank you very much. Let's review the objectives for today's webinar. Participants will learn how neuromuscular diseases affect the respiratory system, discuss early signs and symptoms of respiratory complications and how to manage them, examine the symptoms of long-term respiratory issues, understand the difference between respiratory management in children and adults, and review respiratory equipment. Now let's introduce our speaker. Debbie Rhodes has been a registered respiratory therapist for 21 years. She has worked with Dr. Benson and Dr. Norman since 2005, and also Dr. Kirshen. Her practice includes 5 respiratory therapists that see vent patients statewide, and they have a program with approximately 325 patients. Debbie has been married for 43 years and is a mom to 3 daughters, Mimi to 9 beautiful grandchildren, and has 1 very smart, spoiled fur baby. That's her favorite. Debbie loves to shop, garden, and decorate her home. And with that, I would like to turn the webinar over to Debbie Rhodes.
Thank you, Michelle. Okay, where's here it is. Okay. I appreciate all of you choosing to spend some of your time with us today. Like Michelle said, I am a respiratory therapist, and I'm part of a very small, brilliant team at the MDA Neuromuscular Center at Integra Southwest in Oklahoma City. I did want to make one correction. It's not Dr. Benson, it's Dr. Beeson, and that's B-E-S-O-N. I hope today that I'm able to answer questions that you may have about neuromuscular disease and how it may affect the respiratory system. And also I want to talk about treatment options that are available to you. And with that, we'll go ahead and start with our first slide.
Hey, Debbie, I don't see your presentation yet. Were you able to share it?
Let me see.
Back over
Here.
and then
You want to press the green share screen button again.
okay, so let's
Show taskbar.
go
Right there. Oh, spaz. I want to tell everyone that I am not good at technology.
Okay, so where did our share button go?
That's a good question.
Go to that one, and then now go over there.
Oh, it is here. Here we go.
Is that it? No, you got to share that one.
Yeah, you'll want to click the share button one more time.
Go back here.
Here. Okay.
Mm-hmm. Minimize this for me.
Okay.
Keep going. There we
was.
go.
Okay.
There we go.
Okay.
Thank you. Now click that one. Yep, because that should be that.
Can you see it now?
No, not yet.
Hit share.
Okay. There we go. We're there. I believe we're there.
There we are. We see it.
Okay. Okay. So let's go back to our slide set. And the first thing I want to talk about is we're going to talk about what I hope that I'm able to share with you today. And first thing is we're going to learn how neuromuscular dystrophy can affect breathing. I want to talk about what function a respiratory therapist has in the MDA clinic. And sometimes I'm the funny man, but sometimes I'm really a respiratory therapist as well. What can a respiratory therapist or RT offer outside of the clinic setting? How can a neuromuscular disease patient obtain needed respiratory equipment? What is ventilation and how can it affect my pulmonary health? What is ventilatory muscle dysfunction? And how can that cause respiratory compromise? What are some common symptoms of respiratory compromise? What are supportive therapies for neuromuscular dystrophy respiratory compromise? The functions of those supportive therapies and indications for use. How are therapies different for children versus adults? And what is the most important thing to remember about your equipment? Yeah. Michelle, you're not able to see it, are you?
No, it's still showing us the first slide. Is it moving for you?
Go in here.
Okay.
Or do you want to play from the beginning? Something's wrong. Minimize it for me.
Minimize
Go
this.
ahead. I'll just share your presentation on my end,
Okay.
and you can tell me when to move the slides over. Give me a second while I move it over.
It won't go into present mode.
Is that what it is?
Yeah.
Okay.
So try it one more time.
1 second. I'm just going to stop your share and then go back to mine.
Okay.
Here we are on your screen. Do you see your presentation?
I do.
And I believe we're on this one.
Yes.
So you just let me know when you want me to switch the slide.
My goodness, this is terrible.
That's okay, no problem.
Okay. So in the MDA clinic, there are several of us that go to the clinic, and they're from my team, and we do pulmonary function testing. In that pulmonary function testing, we will do a PFT, which is what we're looking for there is the forced vital capacity. And then we also will do a maneuver where we're measuring diaphragmatic strength, and that also helps us figure out what your cough strength is. We also will conduct an interview, just a brief review of your medical history. We'll take an Untitled CO2, which is a great tool. It's a very accurate, non-invasive reading of the CO2 that's in your blood. And then, of course, basic vital signs to include oxygen saturations. We'll also document your symptomology, and the testing helps give us an overview of the weakness progression. And most often, I will go in and talk to patients first, and then the physicians will go in to follow. Outside of the clinic, an RT's function is delivery of the equipment. We'll take it out, and there's a lot that goes on prior to you getting your equipment. We'll talk about that shortly. And a respiratory therapist will go out, and we will train the patients as well as the caregivers on the use of the device. We'll train on maintenance and cleaning, And also we'll review how they can get disposable supplies. I would also like to point out that in order for your physician to continue to write orders in relationship to this, they do need to see you once a year, at least here in Oklahoma, so that they can sign off on prescriptions for you. Also, on the outpatient side of things, your RT staff will also be available to ask questions to help you deal with issues as they arise. So we see patients in all parts of the spectrum. One thing that sometimes can be very overwhelming for patients as well as family members is diagnosis and equipment setup can happen quickly. Sometimes we don't get to see patients early in their diagnosis. This can all be very overwhelming. Just take your time, learn at your own pace, and we will follow you and continue to help you with your equipment. Our company takes call 24/7, so we're available to you at any time. And, you know, I tell people, be sure and use that privilege. We don't know you're having trouble if we don't know. We want everyone, the physicians, as well as all of the clinic staff, wants everyone to be successful. And we want to improve symptom management, quality of life, and outcomes for you. Okay, so let's get a little bit further into it. I want to talk now about what is ventilation. And you can, there you go. Let's break down ventilation. On the left-hand side of the screen, you can see we've got some lungs there, and you can see the direction. When we inhale, air comes in, and if we are breathing normally, that air will oxygenate the alveoli, which are little grape-like clusters in the bases of your lungs. And they will also, when we get ready to breathe out, they'll offload CO2 that's produced by your body as part of the breathing process. However, if we are not breathing deeply enough, and that would be through no fault of our own, we don't get that exhalation of the CO2 or the oxygenation in the bases of our lungs. So on occasion, we would call this ventilatory muscle dysfunction. And you can see the diaphragm in the bottom of the picture. It sits under the lungs, and then it's above the stomach. Exhalation is a passive motion, and so once we stop breathing in, then we exhale. We don't have to exhale forcefully. Those muscles will relax and the lungs will return to their original size and shape. Part of what helps us take in that deep breath are our intercostal muscles, and those are the muscles that run between the ribs. They pull the ribs up, expanding your thoracic cavity, and then they shrink on exhalation. So of course the red are your intercostal muscles. You can see those in between your ribs. And so I'm hoping that what you're seeing is that your neuromuscular diagnosis can affect the strength of your respiratory muscles as well. And this is just simply another picture of what happens with inhalation and exhalation. Your intercostal muscles will pull up, expanding your ribs, allowing for your lungs to fill up. Your diaphragm pulls down, and then on exhalation, those intercostal muscles will relax, and it essentially shrinks the size of that thoracic cavity. Your diaphragm relaxes and allows for exhalation. I want to talk about some symptoms of respiratory compromise that can be caused by ventilatory muscle dysfunction. Some of the symptoms that we see are fatigue, morning headaches, fragmented sleep, nightmares, possibly the inability to lie flat. Can feel like that it's almost smothering. We can see excessive daytime sleepiness, maybe a diminished ability to be able to concentrate. It can cause depression, shortness of breath at rest and or with exertion. It causes rapid shallow breathing, swallowing issues, and potentially an inability to manage saliva and secretions. I want to talk about supportive therapies that we can use to support our ventilatory status. So one of the, I would say probably the most often used would be ventilation. We also look at airway clearance, and then we also look at secretion management. Okay. All right, so in ventilation, we typically use two types of devices. One of them we call a bi-level positive pressure device. You may commonly hear that referred to as a BiPAP, or we will use a non-invasive ventilator. It varies according to the type of ventilation device we order, may vary based on diagnosis, pediatric versus adult, and what we anticipate the rate of the muscle weakness progression will be. And again, that's related back to diagnosis. We know that some diagnoses are not as heavily affected, or some of them may progress quicker. So we take those factors into account. The bi-level device typically is not as expensive as a non-invasive ventilator is. And if you have a very slow progressing diagnosis, you probably will be able to do fine with the bi-level positive pressure device. If you have one of the more quicker advancing muscle weaknesses, we may go ahead and prescribe a non-invasive ventilator so that it can support you throughout the duration. Also, something to take into account are the pressure requirements, and we don't know that until we get therapy started. And by that, I'm talking about we use pressure to help augment or enhance the breath that you initiate on your own. And then the machine will take that breath and enhance it to get the good lung expansion, to get that air that we're breathing in to go to the bases of your lungs. And then that leaves us with the ability to blow that CO2 off when we exhale by just simply having an adequate sized breath. Another thing that we're going to talk about is airway clearance. And we have to make sure that we are keeping your lungs clean and healthy. And without what we would consider a normal cough, it's virtually impossible to mobilize the natural secretions or aspirated irritants that may come from weakened airways. A cough assistive device is what we utilize to help with someone that does not have a strong cough. And the way that works is it will deliver a breath of air with pressure, positive pressure, and then it takes a quick shift to a negative pressure, and that is mimicking a natural cough. And then there's also, so if you think about the phases of your cough, you have an inspiration, you have that quick shift to expiration, and then you have a pause when you're coughing. And so those are settings that we will set in your device, and we'll titrate or adjust those settings to you. Another portion of airway clearance can include a vibratory vest. And that might be more used in someone that may have an underlying respiratory diagnosis. With most neuromuscular patients, they do not have diseased lungs. You have a disease that affects your muscles of respiration. But if we do have someone that also has some pulmonary symptoms outside of that, the vibratory vest can mobilize secretions from those smaller airways out into the larger airways, and that's done with vibration, and it actually is done wearing a vest. And then we can use the cough assist to grab those secretions that have come out. And that brings me to the last intervention, and that would be your suction device, and that's for secretion management. It's essentially just like what you would have, the dentist would use on you. We have a little soft, flexible device, and you put that in between your teeth and your gums, and you just go back to where you may have those secretions may have come up to your mouth, but you weren't able to get them all the way out. It will pull those out, and that keeps us from having pooled secretions, and it also can help prevent aspiration. Okay, so one of the most important things about the devices that we are ordering, and is they all have, they're powered electrically, but they also can use a lithium-ion battery. These devices are rather small and lightweight. Some of you have had some of the devices for a long time. The cough assistive device used to weigh about 25 pounds. Now it weighs about 12 and a half. And we didn't have the luxury of being able to use those with a battery either. So it makes it very nice to be able for you guys to function outside of home, go to school, those types of things. Some of our patients take them to work. And, you know, if they have all three, it's really important for you to have some way to carry them. And they come with carry bags. That enhances the portability of it, and it also has pockets and places to put the accessories that you need. For the most part, your devices and the regimens are very similar regardless of the age of the patient. Now, I will say that very often we can, you know, you may have a pediatric patient that has the same diagnosis as an adult patient. The pediatric patient may be able to use a bi-level device where the adult patient will need the non-invasive ventilator. And that is typically because, you know, we don't weigh as much when we're pediatric patients. And so therefore it may not require as much pressure to be able to get that augmented or in that enhanced breath. Whereas the older we get, the more we weigh, and it makes our chest cavity, our chest wall heavier and harder to pull up off of the lungs. So for the most part, everything is basically the same. Of course, size of breath and things like that will vary also. So again, to restate, functions of the NIV, it utilizes pressure to enhance the depth of the breath with minimal patient effort, and that enhances ventilation. So what you're seeing on the screen are just a couple of non-invasive ventilators, and the patients that we see from Oklahoma City are going to see one that they're very acclimated to seeing. And then some of our patients will use a mouthpiece device like you're seeing in the bottom of that picture, kind of looks like a snake. And we call that a sip and puff. So we call whatever we're connecting the respiratory assistive device to you as the patient, we call that an interface. So we use a PAP mask. Many of you probably know people that are on CPAP or BiPAP, and we use that same type mask in order to connect you, if you will, to your ventilator. Those come in a nasal form, which that covers your nose. It comes in a full face form, which covers your nose and your mouth. And then we also have something we call nasal pillows. And those will fit up right in the very tips of your nares. And those are extremely comfortable and lightweight. And again, then on the far right hand of the bottom of that, you're seeing the sip and puff arm. And those are to be utilized during the daytime only. You move your mouth in front of the mouthpiece there and kind of use, we call it a kiss technique, where you just touch it with your lip and it will deliver a breath, and then you can move your mouth away. So things have certainly come a long way, even in the amount of time that I've been doing this. The non-invasive ventilator or the BiPAP, our goal is for you to wear those at hours of sleep. You can also use them during the day to help relieve fatigue as needed. Let's say, for instance, you went to school this morning, and today when you got home, you're tired. Put on your breathing device. That offsets the work of breathing off of you and onto the device. You're still in control. You initiate the breath, and then we tell the non-invasive ventilator or the BiPAP, here's how much we want you to help to get this nice, big, deep breath. We are looking to improve alveolar recruitment, which that sounds like a big word, but all we're saying here is that we want to engage those alveoli, those great blood clusters at the bases of your lungs. We want to get them oxygenated, and then we want to blow off that CO2. These two functions helps improve the survivability of a neuromuscular disease. It also can decrease hospitalizations. Typically, those hospitalizations are caused by excess CO2 in the lungs and can cause acute respiratory failure if it's not managed early. I know that probably some of you will correlate the use of a ventilator with being intubated, with having a tube down your throat. That's not the case. That's not what we're speaking of here. And that's why we call it non-invasive ventilation. We're not using the tube in your throat. We're using a PAP mask, which, again, those are so much more comfortable than they used to be. If you have previously used ventilation and are not using it anymore, you might give it a try again. If the interface or the mask was part of the problem, I think that you would be pleasantly surprised to see how lightweight and comfortable they are. Again, we want you to wear it at hours of sleep, but you can use it to relieve fatigue at any time. What I often share with patients is, without this kind of non-invasive support, it's very similar to us running a marathon or running up numerous flights of stairs. And for a neuromuscular patient, this is just for them to be able to breathe. And you could even equate that to like breathing through a straw. It's not very comfortable. The next thing we're going to talk about again is the cough assistive device. We have a couple of manufacturers' devices on here, and I want to talk to you about the cycle that you can get into if we don't take care of your pulmonary hygiene, if we don't keep your lungs ventilated and nice and clean. So the cough assistive devices expand and then they evacuate your lungs, or we're pulling things out. I don't want it to sound like that might be uncomfortable, because that's not the case at all. The device is simply mimicking a natural cough. And that quick shift from inspiratory to expiratory creates a shearing force that helps move those secretions up out of those airways and out of the bases of the lungs and up so that they can come into your mouth and either be spit out, or we can use our portable suction. Also, the cough assistive device can be used to help overcome a choking incident. That's pretty reassuring for people that do have choking issues. And by keeping those things pulled up and out of the lungs, we're helping to prevent respiratory infections that are or can be due to your impaired cough ability. The cough assistive device can also be used to prevent or reverse pneumonia. And so when your physician writes the order for a cough assistive device, he will be writing, or she will be writing, for you to use it therapeutically on a daily basis, because we also want to maintain thoracic recoil and expansion. And if you have had a choking incident, or if you're ill, we can increase pressure and the frequency of the cough assist usage. Or if you have progression of your weakness, we can also increase pressure and frequency. So the cough assistive device can certainly help you overcome a respiratory insult, bronchitis, pneumonia, even a cold. So the cough assist helps break the cycle of inflammation, lung infection, and mucus production. And those things can lead to respiratory failure if they're not taken care of. So we don't get you that cough assist to sit in the floor of your closet. We've got to have it out and we've got to use it. And if you don't use it, if you're don't stay familiar with it, if you were to get choked, you might not remember how to use it. So we also want you to stay familiar with your equipment. Coughing is your body's natural defense to keep your lungs clean, and that helps decrease the risk of infection. So please use it. Okay. One other airway clearance device, and this is a picture of the vibratory vest, and it uses percussion, and it's typically for more difficult to remove secretions. And like I said earlier, can be used for underlying respiratory diagnosis. That the vibratory vest will also enhance lung expansion and mobilization of those secretions. If you are having those repeated severe lung infections caused by the inflammation, mucus production, and then lung infection, we may want you to have a cough assistive device as well as a vibratory vest. Last piece of equipment that we typically talk about is the oral suction device. And those are powered by a lithium-ion battery. In this particular case, it helps make it quieter. It's highly portable, and that battery will last for quite some time. It does come with a nice carry case so that you can see the supplies or the accessories that you need to go with it. You see the little cane-shaped piece in the picture there, and that's exactly like what your dentist uses to pull secretions out of your mouth when you're there. And that will help prevent aspiration in our patients by getting pool secretions from the back of your throat that you may not necessarily be able to move it up and out. It can be very fatiguing to have to cough and get those secretions up. And then it can also, that's compounded by then actually trying to move them out of your mouth. We're also looking to just remove excess saliva. We don't want that to aspirate or go down the wrong way. Some of the concerns that we have as a team, again, I want to speak to the fact that you could get your diagnosis and equipment set up, and those can happen in pretty quick succession. It can be very overwhelming. And sometimes I think that we overwhelm people just by our, we're so anxious to help that we can be overwhelming, and we need to let you learn at your pace, get familiar with it. You just need to understand that we are available for questions and issues. When we leave out of your front door, that doesn't mean you're on your own. And we have on-call services, and we want you to use those. If you do get overwhelmed, that can lead to confusion. You may not understand when to use it, how long to use it, how to clean it, when to change your supplies. There's a lot that goes along with it, and we do understand that. Please reach out to your equipment provider and clarify those things. It's important that we keep everything clean. We certainly don't want anything to be causing any further issues for you. One of the biggest problems that we see, I would say, in my opinion, is noncompliance. So noncompliance in a nutshell means that we have someone that has been provided the device, it's been delivered, they've been trained on it, and then they don't use it. And that can sometimes be caused by either denial of the progression or the severity of the diagnosis. Many times patients will say to me, I'll use it when I need it. And that doesn't, if you understood how hard it was to get your insurance company to pay for your equipment, you'd understand what I'm talking about there. But if we wait to use our equipment until we have serious complications or symptoms, you may be setting yourself up for a long recovery, and we may not be able to get you back to baseline. So we want you to use your equipment, stay familiar with it. Don't wait until you're sick. It could result in an increased CO2. You may see more symptoms of sleepiness. The sicker you get, the more sleepy you'll probably be. Pneumonia is very fatiguing. We also don't want to cause any lung tissue damage. I want to touch back to the process for getting the equipment. After we've done your pulmonary function test, your respiratory evaluation, and we see from those things that you meet qualifying criteria. And that qualifying criteria is set down by your insurance company. Most of them follow Medicare guidelines, so they're pretty much the same across the board. But their criteria that you have to meet in order to be funded for equipment is pretty rigorous. So if we have gotten qualified criteria, your physician has ordered the equipment, we got funding for your equipment from your insurance company, then you do need it. And It's just that you may not realize how much better you'll feel until you start using it. But I can assure you that insurance companies will not buy equipment or pay for services that you don't need. So if you've gotten the physician's order, he's dictated his letter, if you've received the equipment and the training, I can assure you, you need it. So let's choose to follow the medical advice. Let's use the interventions. Now remember, everything is patient choice. And let's say for instance that you have gotten your equipment and you decide, I'm not going to use it. I don't want to use it. I don't want to use it right now. It's always your choice. You can turn it in if you like, but we would like for you to keep it because you did qualify for it. And if you're going to choose wisely. It could be a matter of life and death. Again, we don't want you to hesitate to reach out to your respiratory therapist or the MDA staff for support. We want everyone to be successful by improving your symptom management, your quality of life, and your outcomes. So in closing, I'm wondering if anybody's clapping now that I'm closing. We have your diagnosis. We have done your testing. We've met the qualifications and your equipment has been provided. So now it's up to you. We want you to use it. I would like to go over and see if we've addressed the questions. What kind of a function does a respiratory therapist serve in an MDA clinic? What kind of a function or functions can respiratory therapists offer outside of the clinic setting? How can a neuromuscular disease patient obtain needed respiratory equipment? What is ventilation? How does it affect my pulmonary health? What is ventilatory muscle dysfunction? And how does that cause respiratory compromise? What are some common symptoms of respiratory compromise? And what are some of the supportive therapies? What are their functions? And what are the indication for usage? Are there really differences between children versus adults? And what's the most important thing to remember about your equipment? So,
Sienna, please call Melissa.
With that, I'm at work. With that, I would like to see if anyone has any questions.
Thank you so much for your presentation, Debbie. Yes, we do have questions. Let me go back to sharing my screen. 1 second. And I'll go back. And then I will start with the Q&A. All right. First question that has come in is, let me find it, lost it somewhere. See, we all have technical difficulties.
I was just thinking that's gratifying.
It's not just you. Here we go. Okay. What is the difference between NIV and BiPAP, and how does the doctor decide which one you get?
It will vary it varies from muscular dystrophy clinic, to a different muscular dystrophy clinic. But in our clinic, it is very much driven by diagnosis. And is that a slow progressing diagnosis, or is it one of the faster progressing diagnoses? We can deliver higher pressure requirements with a non-invasive ventilator as opposed to a bi-level or a BiPAP. BiPAPs very often work very well for the pediatric population, just because our chest wall, it does not weigh as much as a pediatric patient as it is an adult. And remember, we're fighting against gravity there to pull that air down into the lungs, to expand those lungs, and to get that inhalation and exhalation deep enough to blow off that CO2 and oxygenate. There was one more part of that question, but I can't remember what it was.
Between a BiPAP
Oh.
and an NIV.
Okay, so a BiPAP or a bi-level, they both, I always tell people, because people sometimes, it worries them when you tell them you're going to get a ventilator brought to your home. That sounds bad. And so I tell them these are boxes that blow air. And the ventilator is the smartest box that blows air, and it blows air with the most pressure. However, a bi-level is not quite as smart of a box, and the pressure limits are a little lower and so it's typically for someone that may not require quite as much support, or that's typically the population that uses that would be the pediatric patients, or someone or an adult with a very slow progressing diagnosis, and they don't have high pressure requirements.
Thank you. Another question that came in, and this might be a local question, but it could be a national one as well. Why is the rental cost so high with NIV?
NIV comes with attached to a respiratory therapist. When you have a ventilator in your home, oh, there's Zoe.
Sorry about that.
When you have a ventilator in your home, you need professional staff to follow it. And someone, that could be a local question, and those ventilators are never owned, so they rent, because you have extensive maintenance that goes along with that. The physicians have to follow those closely because they have varying pressures. There's quite a few things. They also have more expensive accessories, if you will. And very often those patients are wearing it more, or the potential is there for them to wear it more hours in the day. Was that helpful?
If you need any more information on who asked that, please put in the chat or the Q&A. Another question that came in is, who adjusts the cough assist device? If it's set too high, can you be hurt by it?
It can be set too high. However, when we bring it to the home and we train you and your caregivers on it, we will give you some starting pressures. It takes a little bit of getting used to. It can be kind of overwhelming, and we want you guys to trust these devices. And so we may start you at a lower pressure setting, and then we will tell you either you can call and we will make adjustments to that setting, or we also train you on it so that you know how to increase the pressure setting. You know, if you're in control of something, that goes a long way towards you being compliant with it. And we want to empower everyone by teaching them everything we can about your device and about the settings. That's actually an excellent question. And I would say that probably that's one of the biggest complaints, is the cough assist may be set too aggressively. And so people never get acclimated. And so something that I always tell people is we don't know how we don't know you're having trouble if we don't know you're having trouble. Only squeaky wheels get greased. Call us and let us know. Call the clinic. Tell them to call your respiratory therapist and let them know you're having trouble. We don't want to just deliver this equipment. We want you to use it. And it's not doing anyone any good if you're not using it.
We did get a comment about a cough assist, and it said, when I first got my cough assist, I didn't use it because it was very uncomfortable to use. I have learned to love it now. So that totally goes with what your answer was to the question.
Yes, yes. Once you need it, once you get sick enough or it's helped you clear a choking situation or help to prevent a pneumonia, which in turn very likely helps prevent a hospitalization, then you begin to recognize its value a little more. And it can be very overwhelming because we're blowing air in hard and fast, and we can vary how hard and fast we're blowing it in. And then we're reversing that and we're pulling that air back out hard and fast because we're trying to mimic that cough. So it can be alarming.
Another question that has come in is, can the vibratory vest negatively affect people who have kidney stones?
I don't know. That's a good question. That would be a question for your physician and quite possibly your urologist. There is a vest that actually fits like a vest. So when I envision the vest, I look at a regular life vest as opposed to maybe that belt type life vest. And there is an interface, if you will, that very much is like that belt type. And so that would go higher. It wouldn't come down as far. So that's an excellent question, but it's one for a physician.
Thank you. Another question that has come in is, one of our attendees has had a cough assist machine for almost 35 years.
Oh my.
After a tracheotomy in 2010, it has become unused completely and it stays in the closet. Is there a way, since it is already paid for, to update to one of the smaller versions you had pictured in your discussion?
Absolutely. When you go to your physician's visit the next time you're at your clinic, let the physician know that you're interested in getting a replacement device. Insurances will update your devices every so often, and all we need really is supporting documentation. Obviously, the need is still there. Your physician will dictate a note, and it'll be, if you have an insurance that requires an authorization, it'll be submitted for authorization, and then of course it would be delivered. We have people that have their old style cough assist, the ones that weighed about 25 pounds, and then they may get a portable one, which weighs about 12.5 pounds. And that one is actually a little easier for patients to tolerate. Again, it's a smarter box than the old style was. And so they may find that they really, really like the new one much better. But people will still continue to utilize their old one, maybe take it to school, put it in the camper, whatever the case may be. And so, yes, absolutely, you can update those. And I would really encourage it. I think that you would be very pleased.
We have so many questions, so I'm going to keep on chugging along, Debbie. How does the cough assist help overcome choking?
Because of the fact that it has the inspiratory as well as the expiratory force, what we do is, if you're in a choking situation, and that is an excellent question because that's something I did not address. you have the opportunity within the new devices to set different settings. And so here at our clinic, we set a choking setting, and then we also will set a therapeutic setting, which is what you're going to use every day. On the choking setting, we put it in the exhale or the suck only mode, and it basically has that pressure, and it just kind of pulls on it until hopefully we're either able to dislodge it or move it up a little bit, and then you can keep working at it. I do want to remind everyone that if you are choked, call 911 first, and then start using your cough assist device. And if you don't end up needing the 911 help, super, good for you. But if you do need them, they're on their way. And that can have a huge impact on outcomes.
Another question is, does equipment usually come equipped with battery backups? Is there a way to get these items to have in case of an emergency where there is a loss of power?
They do. The non-invasive ventilators, they have an internal battery as well as an external or detachable battery. So they have two battery sources. And typically, I would say the ventilators that I'm very familiar with, depending on settings, last probably, if your battery is fairly new, probably 7 to 8 hours, maybe even more. And so that if there were a power outage, that would give you time to still be able to use your device and move somewhere where there is power, or give power time to come back on. In Oklahoma, we lose power all the time with our fantastic tornadoes, and then there's our snow-nados. So we do have quite a few power outages. The cough assist also has an internal battery, and it can be used with the same external battery as one of the non-invasive ventilators. One of the manufacturers has recently upgraded, and they changed the battery on that one. And as well as the portable suction, that also has a lithium-ion battery. It can be powered electrically, the lithium-ion battery, and then you can also get a power inverter and use the cigarette lighter adapter with a power inverter. So yes, excellent question. And we like for people to take their equipment with them so that they can maintain therapy or be comfortable when they are traveling.
I know we're getting close to the top of the hour, so I will ask 2 more questions if that's okay with you.
Of course.
Are there different masks for the cough assist, one that can be strapped to your face instead of holding the mask to your face?
We don't want to strap the mask to your face because we are, not only are we putting air in, but we're pulling air out. And so we want you to be able to pull away from it. If you have limited use of your hands and you've got a caregiver doing it, we want to be able to get away from it. We don't want to continue to do that kind of therapy without some type of control.
We had a comment saying, very nice presentation, Debbie. And I'll ask one more question since I know we're at the end of the hour and I don't want to take up too much of your time. How do you deal with nasal congestion in your NIV patients?
NIV very often can dry out your nasal passages, your mucous membranes in the lining of your nose. And so very often humidity will help. Now, if the congestion is due to a cold or maybe a sinus infection, you would probably need to get with your physician, maybe see about getting some nose sprays. But I would say very frequently we're able to overcome the congestion just by humidifying, getting adequate humidification. And I will point out that very often at initial setup, we won't put a humidifier on your device because it's so overwhelming. However, again, I want to just let everyone know, we don't know you're having trouble if you don't let us know. If you're too dry, if you're having a lot of nasal congestion, let us know. We do have ideas and tips that can help that. And we'll also let you know, hey, this sounds like something out of our control. Let's get with your physician.
Awesome. Well, that was the Q&A portion of our presentation. We would love to hear your comments about this webinar. Once the webinar is over, a webpage will pop up with a short survey on today's webinar. Please fill it out so that we can help create new webinars with things that you are looking for and things that you want to learn about. I also want to thank our event sponsor, Hillrom. We would not be able to provide events like this if not for their generous support, so thank you very much. I also wanted to thank our guest presenter today, Debbie Rhodes. We sincerely appreciate your time and expertise and everything you do for the neuromuscular disease community. It's my pleasure. Thank you all. If anyone has any questions after this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow back up with you. If you are new to MDA through this program and are diagnosed with one of our over 43 diseases under MDA's umbrella, or are a loved one with someone who is diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. This concludes today's MDA Engage webinar, Maintaining Breathing Function with a Neuromuscular Disease. Thank you very much for attending. Thank you, Debbie, for presenting, and have a great rest of your day. Thank you.